Well, this isn't going to take too long, but this is just, welcome to the millennium, right? The website. This is our new website. It's www.calcianoyouthsymposium.org. It's up and running. And basically, it's pretty self-explanatory, but I just wanted to introduce it. There's great feedback from everyone and from the advisory committee. And our technical guy, Joe Harden, did a wonderful job at putting this thing together. So it's basically, it's about Jon, a little bit of a history about the background, about his life. Introduce Dr. Weinstein. I have the pleasure of sitting on the advisory committee with him once a month. And so, Dr. Weinstein, thank you.
All right, well, good afternoon, and if it hasn't been said, I certainly want to thank everybody for devoting a beautiful Friday afternoon to such an important topic that really affects a lot of us at many different levels. For our second part of our presentation today, we've assembled some community experts from various different areas that I'll be introducing one at a time, and each will give a sort of a brief description of their clinical practice and their interactions dealing with children and adolescents and various cutting and self-mutilation issues. I've been asked to make a couple of announcements before we get started. One is that there is going to be a full-day training in DBT, dialectical behavioral therapy. It will be presented by a psychologist, Tom Mara. It's going to be held Friday, March 16th, 2007, from 9 to 4 p.m. It's going to be at the Longs Marine Lab. The training is offered through the Monterey Bay Psychological Association, and approximately 6 CEUs are available if you're interested. The contact person for this is Jon Girvetz, Girvetz. The number there is area code 831-425-0272, and you can also check their online site, which is linked through our foundation's webpage. It's the Monterey Bay psychassociation.org. But once again, contacting Jon Girvetz at 425-0272 will get you the information you need on this upcoming training. And then, in addition to that, to sort of help our panel members kind of gear some of their responses and statements, it'd be helpful to kind of get a polling of the audience in terms of where you guys are coming from, so that way panel members can kind of get a sense of, how technical or non-technical, when we could use abbreviations and not. But just sort of informally, how many people here are practicing clinicians of some type? Okay, so the majority. Parents in the audience? Well, that are not practicing clinicians.
Didn't think about that.
Okay. Teachers, educators out there? Students, teens. And folks from law enforcement or probation? Okay, all right. So I guess that's a...
Yes, about student counselors.
Oh, any student counselors? Wow, okay, so quite a few. All right, well, that helps. So I guess I would like to begin by introducing one of our panel members, Dr. Robert Brown. Dr. Brown attended the medical school at the University of Texas Medical Branch in Galveston, Texas. He also completed his general psychiatry residency at the University of Texas Medical Branch. In 1997, Dr. Brown moved to Seattle, Washington for child and adolescent psychiatry training at the University of Washington's Children's Hospital and Regional Medical Center. And then after completing his training, he continued as a clinical instructor at Children's Hospital in Seattle. In January of 1999, Dr. Brown moved to Santa Cruz and has been working as a child and adolescent psychiatrist for Children's Mental Health Services of Santa Cruz County, where thankfully he remains to the present. So Dr. Brown.
Thank you. I first want to make a disclaimer. I'm a clinician, not a researcher. I spend most of my day in an 8 by 10 box, working with people. And so I'm realizing coming up here on the stage with the bright lights and all the people in the room, my thinking's regressing more to that of a caveman, or perhaps my speech as well. Not to offend caveman or any politicians that might fall in that category as well. So with that being said, I work for Santa Cruz County Children's Mental Health, and the way in which I interface with suicide or self-injurious behavior is usually kind of down the line. By that I mean, by the time I'm seeing a child or adolescent, they've usually seen therapists in the community, therapists in our own program. They've either been to the emergency room or out of a psychiatric hospital. So I'm usually not as involved in the acute phase of their treatment or management. And my role in the agency tends to be around assessing the need for medication. And what's complicated by that is suicidal behavior or self-injurious behavior doesn't necessarily have a specific medicine directed towards that specific symptom. What we can do is try to treat related or underlying disorders such as depression or anxiety. So my role usually is around getting asked what medications might be helpful or useful, kind of managing the whole big picture, not just suicide or self-injurious behavior.
Okay. Our next panel member is Dr. Peter Holland. Dr. Holland is a board-certified psychiatrist who currently divides his time between the University of California, Santa Cruz campus and a private practice in Aptos. He has served as chief campus psychiatrist at Student Health Center at UC Santa Cruz since 1988. He has extensive experience in working with adolescents and young adults, both in the university setting as well as in his private practice, where he specializes primarily in long-term psychotherapy, including therapy with severely disturbed individuals. Dr. Holland was actually born in London, educated at Cambridge University in England, graduated with first-class honors in theoretical physics. He pursued graduate studies in the physics of elementary particles at UC Berkeley for several years before changing careers. His medical degree is from the Albert Einstein College of Medicine at Yeshiva University in New York City. He completed a psychiatry residency at the Yale University program. He has been involved in planning student mental health initiatives at the University of California-wide as well as a national level, where he was appointed to an American Psychiatric Association task force on mental health on college campuses in 2005. Dr. Holland is presently a candidate in analytic training at the Young Institute in San Francisco. So, Peter.
Thank you. Well, thank you. You know, I'm realizing how wonderful it has been to hear the overview by Dr. McCauley of the kind of material that we work with. And I think I echo Dr. Brown's comment of, and I certainly feel down in the trenches a great deal. And to see the breadth of the data and the view of this as a phenomenon is breathtaking, I think. My own work, I should say, is twofold. I work up at UCSC part-time and run the psychiatry service there. And I work with university students who have a whole range of behaviors, including self-cutting and other self-injurious behaviors. And in that setting, I'm often very much aware of the social setting of what these students do, because they may be living in the dorms, and that can be a glass house. There can be enormous interactions with each other. Very hard to keep any secrets then. The idea of someone making a suicide attempt and keeping it a secret is almost impossible, I would say. And I'm very well aware of the way I think such a society reacts to this act of self-injury that seems to be going against society, and people seem to feel a need to do something about it. In the other part of my work, in long-term therapy with individuals, I certainly see people who do self-injurious behavior. It's obviously for a range of different reasons. And no individual is like any other individual in this. What I see in this setting is how this kind of behavior goes in and out of someone's life and someone's treatment. I've had instances in which such behavior only surfaces a year or two into the treatment. Sometimes people are very ashamed of such behavior, and it takes a long time of getting to know someone before such behavior comes out. And I think I have a sense of people sometimes passing through this behavior, although often going back to it, particularly when there's a traumatic history. People often repeat a great deal and go back again and again to such behavior. This is something that very much comes up in the work between myself and the person. One thought I had in approaching this topic is that there is a kind of passage in this, or a rite of passage in this, that people are passing through a transition from adolescence to adulthood. This is a very dangerous transition, of course, in some ways, but it's also a transition between one's life not being one's own to one's life being more one's own. And I think that transition does need to be respected, although we clearly do listen to the risks of the behaviors that occur in that. Perhaps we have to bear in mind, some anthropology here too, that any society has some kind of initiation into adulthood. Our society perhaps doesn't do so well in formal initiation, and people often discover their own. And sometimes that can be a very dysfunctional, from our point of view, a very dysfunctional way of behaving. But it's also, I think, something we have to listen to as to what is going on in the person's life.
Thank you. Our next panel member, Bruce Neustadter, has more than 25 years of experience working with high-risk adolescents. He graduated from UC Santa Barbara with a background in developmental psychology. In his work, he has focused on identifying developmental issues that impede healthy teen behavior. He has dedicated a significant amount of his time to school-based programs for high-risk youth. This includes an expertise in program development and intervention strategies. He also maintains a full-time private practice in Santa Cruz and works as Delta Charter School for high-risk youth. Bruce.
I too am having an interesting experience sitting up here. I feel like some of the kids that I work with under the spotlight and uncomfortable with all these people staring at me. But as the kids do too, they have a barrier and a block to them, which I have a table in front of me. My work varies between two contexts. I spend a large amount of my time in private practice, primarily with adolescents and families. And I also have the opportunity to work in school-based programs, particularly right now at Delta School, which I've been at for 13 years. Probably the most interesting work is at the school-based program because it provides a context and understanding to how these high-risk kids function out in the environment. Generally, my experience has been is that somehow context is limited within an office setting, and school settings have provided me an excellent opportunity to get a better understanding of context for the kids that I'm working with, which has given me information and understanding about the functionality of their self-injurious behavior. It has a context and understanding that I can utilize out in the world as opposed to bringing it into the room. And I think as Dr. Holland pointed out, I think when you're in the context of a one-on-one relationship or with your family, it's much more difficult to bring out because there's a sense of shame, they're trying to hide it, there's a way in which developmentally they don't want to talk about it, even though we all may know what's going on, or I may not going to talk, may know what's going on. It's the old question of, what's that scratch that you have on you? And they say, well, it's a cat. And I ask, well, what's the name of your cat? And of course they can't come up with the name of the cat because they don't really have a cat. It's walking down that road gently and kindly with the kids that I work with. Another primary focus of mine is I think that traditionally, at least in the work when I first started out, is there was a bias to believe that the majority of self-injurious behavior was in the female population. And maybe because I tend to work with a lot of males, I see a large portion of adolescents that participate in self-injurious behavior as male. Unfortunately, as we know in the realm of suicide, often it tends to be more dramatic, often more dangerous, and in certain ways often more hidden. For instance, some of the males that I work with cut on their legs. Well, you wouldn't know that if you saw their arms. So I contextually, my experience is that being out in the world is a good venue to understand this issue.
Thank you. Our next panel member, Dr. Suzanne Nicholas, is a psychologist in private practice in Santa Cruz. She is also on the residential crisis program staff at UC Santa Cruz. In addition to her career as a psychologist, Suzanne is a counselor for Costa Noa High School in Santa Cruz School District. She has a special interest in working with at-risk and sexual minority youth. Suzanne.
Thank you, Greg. Thank you. I have actually the privilege of working in a couple of different trenches, and they are very, very different. One is the trench of being a high school counselor working with at-risk youth. And my entire time, 25 years as a high school counselor, I have been working in alternative schools where we really do have the majority of students who are dealing with high-risk behaviors and issues in their lives that are causing them trouble. The other trench I happen to work in is in private practice and also at the university working with the crisis program there. So being one of the first people online that gets called in the middle of the night when someone has attempted suicide. And then in my private practice, I work a lot with university students who are very different from my at-risk youth that I see during the day at my high school. So I really have a broad range of young people that I get to see. And what I've been struck with recently is that in both in my private practice and in my work at the high school, that I have actually seen more and more students talking about self-harm. And what's interesting for me in particular is at my high school, kids are actually quite open about it and seem to identify that way quite a lot. I know one of the issues that Dr. McCauley talked about was the contagion effect, and I think that that's a lot that happens in schools. You get, pods of kids who are using that as a coping mechanism and sort of sharing that information with each other. And we certainly see that a lot in schools. I recently started a young women's empowerment group, and before getting into the group, I had all the young women do a survey on the things that they wanted to speak about in the group and things that were of interest in them. 3/4 of those young women talked about wanting to talk about self-harm and cutting, which was really surprising to me, but that they were so open and willing to actually write that down, that they themselves wanted to do that. So I think there are two things to look at with that. One is that I think that in some ways that's really great for us that they're talking about it, because then we can identify them and work with them right away, and if it's less hidden. Of course, the other side of that is the contagion effect, that the more they are talking about it, then the more it seems to be happening. So that's, I think, what we're dealing with a lot in schools, and my fellow counselors, high school counselors here, are really dealing with that a lot too, in addition to all the other things on the plate of a high school counselor are these very serious issues. The other thing that is a real interest to me is working with sexual minority youth. And there's certainly a substantial amount of research talking about suicide and the increased risk for suicide behavior in sexual minority youth. There's really very little, if no, information about other kinds of self-harm in sexual minority youth, but there's certainly some idea that those young people would be more vulnerable to that. Although that is not what I've found in my own work, and I think that is because in our community, I think that we have a lot of support for sexual minority youth, and I think many communities around the country now that we're seeing a real change in that. Rich Savin-Williams out of Cornell, who writes a lot about the positive aspects of sexual minority youth, really talks about that as well, that sexual minority youth are way ahead of us in terms of, that's no big deal to them. Many of them talk about that in that way. And really, the students that we're going to be worried about are those young people who are hiding that and confused about that, not the students that we see who are out and proud and talking about who they are as a sexual minority youth. So thank you.
Thank you.
Our next panel member is Amy Pine, who is a psychotherapist and expressive arts therapist who has been practicing in Santa Cruz for 22 years. She has worked in a wide variety of mental health treatment settings and maintains a private practice, seeing individuals, couples, and leading groups for women who are healing from childhood sexual traumas. She specializes in working with clients with post-traumatic stress disorder, as well as dissociative identity disorder and various attachment disorders. Amy is co-founder and still a member with the board of directors of Survivors Healing Center, a nonprofit organization whose mission it is to provide for adult survivors of childhood sexual abuse and stop the continued victimization of children. Amy.
Thank you. For the past 22 years, I've been working predominantly with adults and young adults and adolescents who are survivors of childhood sexual abuse. And among the people that I work with, both individually and in therapy groups and retreats, there's a very, very high percentage of the women who use self-harming behaviors as a way to cope. And I have been looking a lot lately at the self-harming behaviors in the context of attachment disorders. Of course, there's a lot of meanings and purposes for why people are hurting themselves, cutting, burning, hitting themselves. And so I see that more and more as people's effort to try to cope with what's happening in their life and what's happened in their history all by themselves. It's definitely something that people have relied on to survive without the sense of support and connection in their life. I tend to work with people long-term in my individual practice when I see people as individuals, and a very key part of the work that I do with people is in the relationship that I have with them. And that's been, for the most part, a huge, huge missing ingredient in their lives. And listening to the talk this morning, I was reflecting to myself about how many of the elements of why people are cutting and what we can do about it that really may be very importantly addressed in looking at the kinds of relationships that we're providing to the people that come to see us. So for me, that's a core ingredient. Thank you.
Thank you. And then, of course, we have Dr. McCauley, who has been gracious enough to stick with us here for the speaker panel as well. And so, the questions. So here's a question that was actually directed to several of the different panel members, so I'll just throw it out there, and whoever thinks they may want to comment can chime in. The question was, what is felt to be an effective intervention in a crisis situation in a school setting where there is resistance both on the part of the adolescent as well as the family to receive treatment?
Oh, please go.
I'll go ahead and talk about that from a school setting, because certainly something that I've experienced before, and I know who wrote this question. I think in a school setting, like it or not, we're really the front line. And if something is happening in the world, in our society, we see it first. And I say a lot that the students that I see in my private practice are very different, are different than the kids that I see in my school, because the kids in my school are not going to walk to my private practice for the most part. So we're really dealing a lot of times with kids with with that resistance. And I think as a counselor and as school personnel, definitely the number one thing is sort of the contact and the connection with parents. But that, as you said, that's not always the easiest thing to do, and there very often is some resistance to that. But what I find with parents is sort of the more we sort of work with them and try to be on their side in that and try to be their support, because I think very often parents feel blamed when we call them about these things, that there's something wrong with the kids, so that means there's something wrong with me and my parenting. So really sort of sitting on the same side as the parent is sort of one of the best things that we can do as school personnel, and instead of it making it an us or them. As soon as we can get kids into treatment, that's very important, because we're not a treatment agency at schools, but we very often by default end up being that. So we try to get kids into treatment as soon as possible. We have great connections with people like youth services, and we also have in our schools, in Santa Cruz City Schools, we have interns who are providing extra support for us as well, so sometimes we can use them as sort of an interim support for our students who don't have access to care outside of school. The other thing that I would say is just it's sort of what many of us are already doing in schools, is to do that ongoing check-in, that kids very often feel like they don't really matter and they don't really count at school, and if you have an adult who's checking in with you, it just makes an entire difference in the world. So to have an adult actually checking in with you every day to make sure you're okay, I think is very helpful with reducing the incidence of having the kid feel alone and isolated, and also then reducing the incidence of self-harm. Bruce, maybe you have some additions there.
I thought of an old story years ago when I was working at Family Services, which was always interesting. I had a 14-year-old girl come in with her family, and she had taken rat poison, which in my mind is a fairly significant, dangerous move. And I was sitting with a family, and the older brother said, well, she's just trying to get attention. That was the context for the family, is that everybody thought she was trying to get attention. And my intent in that moment was to educate the family of the seriousness of her action, that whatever her intention was, is that the outcome was almost death, and then it was serious. And so in situations where I'm meeting kids, and my view about, sometimes we talk about the concept of resistance, that for me an adolescent isn't resistant. I mean, as I pointed out, I don't think any kid wants to be in the spotlight in any context, let alone to be sitting in a group of adults talking about the fact that they're cutting on themselves or they burned themselves. So I think there's a tenderness and a gentleness, and I also think there's the stark reality that this person, this human being, is at risk. And I think the intention of intervening in a school environment is to present that risk in such a way that everybody in the room understands it. Whether they're bought into it immediately, I don't think is necessarily important, but that they understand the risk. The intent of where the action can go is the beginning. The other thing that I utilize in school environment is to get as many adults involved as necessary. And if I truly think that the student's at risk because the parents are unwilling to go get involved, I will use other resources. We have the Sheriff's Department, not as a threat, but as a statement of seriousness, as a statement of reporting to the parents that I thought this was serious enough to have a sheriff sitting there talking about that this student is a danger. I think it's incredibly important to use community resources and utilize a broader base of intervention when you have people that are nervous or uncomfortable or have their own issues about why they're in this context. And that's what we do in the school. And then, as Suzanne presented, constant follow-up. I mean, initially daily. At least in, I think in high-risk environments such as the schools that we work in, we have lots of resources and we utilize those resources. So the principal's checking in, I'm checking in. If the special ed teacher has a relationship, she's checking in. So we have constant monitoring of this student's behavior on a daily basis. And the last piece is exposure. And I mean that in a very gentle and kind way, but I think it's critical that the student or the child that's harming them understand that everybody knows it's going on, that they understand that everybody is there to understand what's happening for them in their context. And I think that's critical, at least in my work of working with self-harm kids, is that there need to be people who know. Thank you.
That's good. And, you know, I would echo that as well, Bruce. Last week I had a young man in my office who had been for months cutting, and all his friends knew, but they were all keeping it a secret and sort of doing this group behavior around it. Finally, one of his friends got really scared and told her parents, and her parents told his parents, and this young man said to me, "I'm so grateful for her to do it, that she did that. I could never tell anybody to do that, but I'm so grateful that she did it," because it got him into treatment and got him the attention of adults, which he was not talking to any adults about it. So I think that's really essential.
Thank you. Maybe this one, possibly Peter might help field. How do I determine the seriousness of self-injurious behavior in the adolescent when he or she says he or she is doing it simply to fit in, to be popular or accepted? Lots of kids are doing it, and it's really not a big deal. Easy one.
That's not such an easy one. And clearly there's something about one's relationship with this person that a lot's going to depend on here. I think all of us who've done evaluations in emergency settings of adolescents in emergency settings know this cycle of the adolescent blustering, needing to take control, needing to say that they know exactly what's going on. And I think it takes a little time, and that's always a tricky thing in different settings, both emergency settings, private office settings, how one does the time of this. But some time to listen and wait, and some feedback that is slowly going to give some other facts. And listening to what Suzanne and Bruce are saying about providing the facts of what is true for the situation. It depends a lot on the setting and one's relationship, how blunt one may be with those facts, I think. But at some point, there's going to be a tension around those facts and what your relationship with the adolescent is going to be, with you going from listening to a mode of being there with something different. And I think this is part of the trick or skill of therapy, even in an emergency setting, to make that transition, so that there's the possibility of getting onto a new thing, which is talking about what the person also knows beneath the bluster, that there's a problem. And bringing in other people, of course, the parents that are there, perhaps friends that are there, about the reality of what's going on is also very useful.
Thank you. Anyone else want to sort of comment that the whole sort of theme of, my friends are doing it and such seems to come up in these questions quite a bit, and is that an issue that you run across in practice when adolescents are basically justifying their behavior based on that?
I would just add, a number of people have talked about this issue of relationship, and I think that, one of the key issues is us being able to learn how to tolerate our own anxiety while we go through the process of being open to listening to what the behavior means for the youth and moving towards change kind of engagement or talk. And I think that can be really, your anxiety can get high, so you want change right away, but you're not going to necessarily get it. And so it's the importance of that, being able to be calm in yourself while you're listening. What does it mean for this person? What purpose does it serve? How does it fit in their scheme? and gradually encourage move to change kind of talk, and then hopefully to change. But I do think I just wanted to acknowledge that it can be hard to sit there as the therapist. I think particularly in an emergency situation where you're, kind of all eyes are upon you to do something and to make a plan that's going to keep everybody safe.
I think that trust is, everyone's referring to a process where you develop trust between you and your client. And I find that in that process, that my clients have to understand that my caring and my concern is really authentic, so it goes with the getting to know and the timing, and sometimes also sharing my own concern and my own sadness that they are hurting themselves, and without overwhelming people with that, with my issue, to communicate and convey that I really do care about what happens in that way.
The next question was for Dr. McCauley. Is there any research or indication as to why the quote-unquote cutting behavior has become so prevalent? I'd never heard of it during my training in the 70s.
I don't think that there's a research study that comprehensively answers that. I think that there's some hypotheses or trends out there that people are considering. One, I think, is that, not that this is new, but I think that we have learned a lot or gotten better at understanding the whole issue of the impact of early trauma. And I think that as we gain better understanding and focus on early trauma, I think we see this as a sequelae or a down the road kind of component. And so as early trauma gets identified, it may only get identified in the context of the behavior, the self-harming behavior as it presents later on. I think that the other issue has to do with this issue of contagion, which is a very, we see copycat behavior in adults. It's in the literature. I don't work with adults, but in adults who engage in self-harming behavior. For instance, there was a study that was done in Europe that when they didn't publicize an adult who had jumped to his death in a subway, they took a particular public information approach to that and discovered that there was much less of a copycat effect than they had seen in other similar instances. So it's not that it doesn't happen in adults, but this contagion group effect is something that's very unique both for suicidal behavior and for self-harm behavior among adolescents. It's much less common among adults. So I think that's an important feature that kids are talking about it. And then I'm going to really go out on a limb, so this is not research, but I do think there's an issue that we need to get a better understanding about, is how does it fit in the whole need to take risks that adolescence, that we think has forever been, since adolescence was identified as a developmental period, the need to take risks, or the taking risks as part of adolescent development, has been one of the preeminent issues. And I think that this is a form of risk-taking behavior that pushes the envelope to a place that's definitely going to make your parents, your teachers, your peers, in some instances, uncomfortable with your behavior. So it is, I think, fits in that. That's another issue that we need to get a better understanding of. But I would certainly defer to other people about if they know the literature on why. I don't think we totally know.
Yeah. Well, the literature may not have caught up with it yet, and so.
I do think that there was such behavior in the 70s, certainly in adolescent hospitals.
Right.
If one looks at the memoirs from the period, I mean, Girl Interrupted, I Never Promised You a Rose Garden, over a period of time there. And I think our own memories of different times of training, that this is a universal behavior, that it may have been much more hidden for people as outpatients and much less reported than we know. The other thing that I'm thinking is that there has been a different attitude towards, showing alterations of body and skin in the last 10, 20 years. Tattooing, sometimes there is very little difference one can see between extreme tattooing and putting up with the pain of extreme tattoos and self-injury and other extreme things to do to the body. That isn't new. Again, if one looks anthropologically, this is not new at all. But a certain veneer of society made this unacceptable, at least for mainstream society, and mainstream adolescence in the 60s, 70s, I think. Perhaps some subcultures, not so.
Thank you. Dr. Brown, a question regarding the endorphin response to cutting, the high, the sense of euphoria that people who self-mutilate will often report. Could you please maybe comment on that, and also as a way of possible pharmacological treatment in terms of medications that might block that euphoric effect as a way of cutting down on the cutting behavior?
Okay. Well, I have to admit I'm not really familiar with what the newer research may be on that. There's some research as it relates to self-injurious behavior for children with developmental delays or autism that, perhaps a reason why their injury might be different, in which people have tried medicines like naltrexone to try to block that opioid response. And, from what I remember, that literature, it wasn't a really robust kind of response. And I don't think, at least in terms of mainstream child psychiatry, I don't see most people using those medicines for people who have self-injurious behavior, certainly not as like a first or second line agent. And we're probably going to focus more on the non-pharmacological treatments rather than relying on that. So I would say probably, as mentioned in the slide, the group of medicines that we're most likely to use in connection to self-injurious behavior would be the SSRI antidepressants. And maybe Dr. McCauley knows if there's anything newer on the opioid.
Well, just what I summarized, but I think that the other issue, and I'll defer to you guys to comment more on this, is I do think that there's that kind of, that the SSRIs may have a role in diminishing the kind of obsessive, worry, focus, repeated thought process that can get a kid that they can't get away from, and so they do some of these behaviors to get away from it. So I think that it's not a direct effect. I think it just gives some relief, but I defer to you guys that's prescribed to respond more to that.
Yeah, I mean, I think we certainly, if there's a kind of a ruminating or obsessive response, I think it can tone it down. But I would definitely caution, though, even for treating anxiety disorders and depression, it's not like it eliminates all the symptoms. People may report 40, 50% relief, but it's not like it's all gone. And so, I think while medicines have a role, there's some limitation in terms of how far they're going to take you.
Let's see, here's a question. Perhaps Bruce could field this one. Is it possible that the rates of self-injurious behaviors for boys are so low by comparison to girls is in part due to the boys' increasing engagement in dangerous behaviors? Is it a way to self-injure with the acceptance of society? Commenting how many teenage boys exhibit total disregard for their bodies and almost revel in the sustaining of injuries.
It's a lot of words. Let's see where to start on that one. Well, again, I'm not necessarily convinced statistically, because some of at least the information that I've read, and I know some of it was a few years back, the research was finding that about 64% of females were participating in self-injurious and the rest were males, and that in some studies they found that it was almost equal. So I guess I want to state that as a precursor, that in a way I don't necessarily know that there's a radical differentiation. It may be in terms of exposure, in terms of clinical settings or school settings and reporting of it. Clearly, when we look at male behavior, I think it would be likely to say that certain males have more extreme behavior, and that in ways that could be also identified as self-injurious. So you could take, I remember a skateboarder I used to work with who was fairly adept at skateboarding, and yet every time he came in, I mean, there were significant injuries that were escalating. So it was beyond the point of, in a way, that he was participating in skateboarding. We started focusing on the fact that he was coming in with his elbows torn up or his knees torn up. And, you know, we're talking about severe injuries where lacerations of, 6 to 8 inches across his body. So I do think there are other forms and methods in which males can participate in self-destructive behavior. The other piece that we haven't talked about that I also think is self-injurious is substance abuse. And especially around issues of drinking and alcoholism and blacking out, and some of the behavior and consequences of that drinking turns out to be self-injurious because they often harm themselves in the process of excess drinking, whether they fall down, whether they get a concussion, or those kinds of pieces. So in general, what I tend to do in terms of looking for a baseline is look at the depressive aspects, or are they looking for some kind of relief, which I think at some point we probably talk about. A relief is an action to either the numbness that they're feeling inside or the intent not to feel bad anymore. And that this self-injurious behavior, whether it's among males or females, provides that relief.
Would someone like to comment on the apparent correlation between self-injury, self-mutilation with childhood traumas, sexual abuse, and such? Amy?
Yeah, well, we recently at Survivors Healing Center, we did a series of focus groups with organizations in town, ranging from criminal justice, probation, women's health organizations, drug and alcohol, and asking them about how many of their clients they estimated. It was an informal informal study, but they're estimating anywhere from like 30 to 80% of the people that they're dealing with are survivors of childhood sexual abuse. So certainly childhood trauma, childhood sexual trauma, maybe even in particular, is definitely a huge precursor to self-harming behavior. So we see that extensively among the clients that come to Survivors Healing Center for groups and services, 50, 60, 70%. And so, you know, it's an epidemic, it's a pandemic that is really at the core, I think, of a lot of self-injurious and self-harming behavior, and hopefully we're going to keep on waking up to addressing that as a core problem and precursor.
Any theories as to why there's the connection? So there's, I mean, sort of anecdotally, obviously you're seeing it, but from a biological or psychological standpoint, why there might be that cause and effect?
I don't know about the biological explanation, but again, a child who's growing up in a family where either within the family or somehow a family is not responding to a child being traumatized so extensively is looking for a way or ways to cope with something that's so beyond their means to cope with on their own. And so, you know, cutting or burning or hurting oneself can do a lot of different things, as everybody's been talking about. It can help somebody to feel better. I hear a lot about how it's a way to get the punishment over with and be in charge of the punishment so that there's a sense of control about that. Sometimes it's a way to begin to feel when somebody's feeling completely depersonalized and they just feel like they're not even really there at all, a way to come back. Sometimes it's a way for survivors of child sexual abuse to express the kind of rage and desperation that they're not allowed to express or isn't being heard in other places.
I think it's important to recognize that cutting and other self-injurious behaviors are symbolic acts. And as symbolic acts, they are expressions of communication. They are getting to deeper issues of the person. People who have gone through deep traumas, sexual abuse or other traumas, who very often use dissociation as a defense, are often trying to find ways of connection. And the skin is certainly a place of that connection. I tend to think that the dissociation, which is a very common defense of very severe trauma, is exactly what leads to other ways to symbolize than ordinary language. And this is a way of symbolizing that is on a very deep level, a infantile child level of connection to others through the skin too.
I would also want to add that I think as clinicians, I think we have to be respectful on some level of our clients and our students and people in our lives that are using this as a coping mechanism and perhaps the only coping mechanism that we know. And so there's I think we need to be respectful of that as even though we are horrified by it by some extent as well, but to be respectful that this is what this young person is doing to survive at this point, that this is perhaps the thing that's keeping them from killing themselves, from going crazy, that they're using this to manage. And I think when we can talk about that with our clients, with our students, that also gives them a sense of hope that they are actually doing something. We don't want to sort of say that it's doing something that's good, but if we can kind of frame it in that way, you're doing things that, to be able to cope and to be able to move on in your life. Let's look at some other ways that you can cope. Let's talk about other strategies. But I think that there's some danger in discounting that behavior as just a bad behavior or maladaptive behavior. That I think it's really important to respect it.
I'd like to make the comment too that I think for some in the audience, when we talk about sexual abuse, I think sometimes people think of that as like a single event, and there's been some study that there's a big difference between being exposed to a single traumatic event versus a number of chronic kind of traumatic events, that people who have been exposed to sort of repeated trauma, and it doesn't necessarily have to get to the level of sexual abuse, are going to have a much harder time of things into adulthood. There's a researcher, Charles Nemeroff, who's actually looking at that repeated exposure may actually affect some long-lasting changes in the brain. So when we talk about sexual abuse, I think one of the issues that might be hard to study the connection is that it comes in the context of many other things going on in most cases. I work with kids who are coming out of the foster care system, and it's more than just the sexual abuse. It's all the things that sort of go on that sort of allow that maybe to happen or for that to occur. So I think it's important to remember too that oftentimes it's not a single event necessarily. It's a multitude of other stressors and problems that have revolved around that.
I wanted to add to what Suzanne said, that in terms of clinical treatment, I think it's very important that we be very aware of our potential desire to immediately contain the behavior. As has stated earlier, it's uncomfortable to sit with yourself and have, a 14-year-old kid show you their arm that's completely hacked up. It's painful, it's hard to look at, and it is their coping strategy. And it's critically important that we be aware of the difference between our uncomfortableness and our need to take away their primary coping strategy when we're interacting with them. It's not to say that containment over time is not our intent and to help them develop other ways of coping in the world. It's just to say that we potentially risk our relationship with them and risk their own sense of self by trying to contain that behavior quickly out of our own need.
Yeah, it's a valid point. So the other question has to do with obstacles to treatment as well. In this person's clinical practice, it seems that the clients who self-injure are least likely to be able to name their emotional states and most likely to be detached and dissociated, making cognitive behavioral interventions more challenging. Can you comment then on how using a cognitive behavioral technique in someone who is detached from their emotional state can be done?
I'll start, and then hopefully some of the other folks will jump in. I feel like one of the things that is both challenging, but for me, and I think probably for the other people here, fun about working with adolescents is you get such a broad range of developmental sophistication. And so I think that the importance, and we've all talked about this, of kind of starting from where people are at the moment. So I think what I would suggest as a first strategy is that you just step way back and begin to do some simple education about kind of emotions, the kinds of thing that you might think about as appropriate for a much younger kid. I do a lot of consultation to the mental health programs in the Seattle Public Schools, and one of the we have a mental health services in our high schools and many of our middle schools, which is a wonderful thing. But we talk a lot about this need to go way, way back to what seems like square minus 10 or 3 or something, and just do education about how you recognize your emotions physiologically, how do you respond, some of the very basic kinds of things that you can look at. Some of the work that they've done at Temple University, that kind of coping cat and some of those anxiety coping manuals. I'm not saying you would want to use necessarily the whole manual, but they have really nice little exercises you can do with kids about just trying to figure out what is emotionally going on for them. But it does mean being able to sit with your distress for a while and realize that you're going to have to do some prep work before you can engage in what you might ideally think about as a more active or developmentally appropriate intervention strategy. So I think it's just important to, if that's where you're starting, that's good, and kind of reinforce what people have said about people are doing the best they can, and you need to start with what they need, and it may be very simple education before they can even begin to build a relationship or as they're building a relationship, so they learn a little bit to pay attention to their bodies, to their feelings, to their triggers. And the nice thing about it, and I'm really interested if maybe people don't agree at all, is it also can buy you a little bit of time to get a better sense of what's going on with the kid and to develop a little bit of that relationship. So you're doing what seems like not very threatening, certainly, and very preliminary work, but it gets you on a little bit of you can develop that relationship and so to work to be able to take the next step in terms of the work you do.
I would add that I think it is very hard for our clients to do cognitive behavioral work when they're in a state of hyperarousal or dissociated. And I do a lot of work with people around their bodies and learning how to just take a breath, learning how to get a little more grounded, how to calm down a bit, how to take a little bit of time, and just to how to learn how to contain. And then it starts to be a little bit easier for people to think. One client recently said to me, as soon as I get in this state of agitation, the thinking just goes right out the window. There's no more thinking on board. So working with the body.
But even that is a mastery experience for many adolescents, that they know that they can calm. I mean, that's a basic thing they haven't. So it's an important step.
I think we do a lot of very, from outside, very strange things when we work with adolescents. I've spent whole sessions, several in a row, simply drumming on my knees with an adolescent. There's different ways, I think, of being in contact. And, you know, we know that deep down what's going to make the difference is the feeling of contact that they have and one's own ability to tolerate their own anxiety and maybe their strangeness, and perhaps how strange we feel when we're doing some of these things with them, too. I think tolerating anxiety is only one aspect. We have to tolerate us being adolescents, too. I should say I did notice in one of the slides the description of why adolescents are so vulnerable, that they are prone to biased interpretations of experiences, self-criticality, low inhibitory control, and emotion-based coping. Describes at least me, and I think most of us pretty well.
In terms of recognizing I actually think cognitive behavioral therapy does a good job, you know, particularly if you help normalize with people if nothing else, the physiological arousal things that may be going on. I mean, what I find is sometimes adolescents, you know, if I ask them, you know, do you ever get muscle tension? Do you ever get short of breath? They're going to say, no, no, no. And, you know, they're sitting there like this and the opposite, you know. I think sometimes, you know, feedback, I think sometimes normalizing and giving examples of what people experience when they have those physiological symptoms is helpful, because then they go, oh yeah, I have that. You know, it's like, you know, does your heart race? No. It's like, does your heart ever pound really hard and make you, you know, feel like you're trying to catch your breath? I mean, I think there's ways to do that. The other thing is that it's not like I think there's tools that you can use to help prompt them. You know, it's like, you know, sending them home with a blank pad of paper and say, you know, tell me what kind of feelings you have at home, you know, your emotional feelings, your physical feelings, might work for some, but others might need, you know, kind of a listing that they can just sort of check off and need some definition sort of ahead of time of what that actually means. So I think that actually in most adolescents you can, you know, find a way to get them to understand kind of what it is that you're wanting to get a better understanding of and how often they actually have those experiences.
I would also want to add, adolescents, like most of us, are really interested in knowing a lot about ourselves, and they actually haven't had much experience having people actually talk to them about who they are and what they feel. And I think that can be very valuable, and it's another, as Dr. McCauley said, another backing up strategy of, you know, backing up from the emergency, the really big stuff that they're talking about, to talk more about sort of who they are. And some of you may have seen in the paper recently at my high school, Costanoa High School, we have a young man named Jason Murphy who's been coming in and teaching our adolescents, our high-risk youth, mindfulness-based stress reduction. And a couple days ago in school we had a kid who was really, he actually ended up having quite a serious problem later, but he was having somewhat of a manic state, really having a hard time containing himself. And he's, in the middle of me talking to him, he said, okay, let me take a breath. And he took a breath. He did a little mindfulness thing. And he said, okay, Jason taught me that. And, you know, now I can do that. And he actually just demonstrated this skill. And I was able then to sort of talk with him about that skill and how he learned it, what he noticed when he did that. It's a very, very simple skill, but so incredibly powerful for an adolescent to know that they can actually affect change in their body. It's very powerful for them. So I think just a little techniques like that we can teach kids about discovering who they are could be very helpful.
Another piece is, I think, at least in my experience of working with teenagers is they're very resilient and they're very resourceful. And though developmentally they may have adapted to maladaptive behaviors, I think it's really important to point out their excellence. I remember years ago I had a teenager come in with his mom, and he refused to talk. And generally my experience is that, you know, halfway through the session they get somewhat irritated and they'll say something. This kid was brilliant. He sat through the entire session mute. And so what I wanted to do is I wanted to acknowledge his brilliance, and I looked over him and I said, "You're good." And he said, "Thank you." My point is this, is that it's important, as we talk about this backing up strategy, that we acknowledge and recognize that for whatever reason that we're having contact with them in the moment, they have a brilliance and an adaptation that we need to find as a beginning to help them get back on track. And that's a slow, quiet process in watching them and seeing who they are and discovering how they see the world.
From the questions here, I'm getting the sense that the audience is, you know, understanding the importance of kind of sitting with our own anxiety, establishing the trust and relationship. But I get a handful of questions ranging from, you know, a pediatrician who has, you know, 8 minutes to see the patient to a school nurse who has a huge caseload. You know, what do they do? What are some of the resources that they can go to locally to get some backup with people that do have the time and expertise that it really does take to work with this population? Anybody want to tackle that?
Is that where can they find resources, or who do they turn to?
Local resources, who would they turn to because they simply don't have either the training, the time to do the work?
Well,
Besides, we'll give them all your phone number, so.
Yeah. Do you want me to list the phone number? I think, the county mental health programs, in contrast to other states I've even worked in, interface across different arenas, and there's, unfortunately, access to mental health is probably more complicated than it needs to be. I think people are constantly working on trying to streamline that. Most people know how to go to their doctor, but most people aren't sure, well, how do I get mental health help? I think, one way for some people is to, contact, if they have an insurance provider, contact them to see, who might be, in the local community that they contract with. We have an access number that's a 1-800 number that you can call non-emergently to help kind of sort out, where some of the local resources might be. Of course, there's listings in the yellow pages in the phone book. You may also, depending on where this might be occurring, you can talk to folks in the school or the other places you're at. But in terms of helping sort that out, we do have a 1-800 number here locally. And of course, if it's something emergent, then I always tell people, don't hesitate to call 911. I can't tell you the number of times that we'll get calls, that are really emergent. That there's just no way that I'm going to be able to be wherever that person is at, in time to have an intervention. And I think sometimes what we often do is just help people know, it's okay. That's what that service is there for. I don't know. I think the listings are actually in. There's handouts in the brochures. I don't know if you want to mention the number for taping purposes or.
Well, if it's in the brochure, they'll have it there.
Okay. Do you want me to mention it?
Oh, sure, please.
Okay. So the at least for county mental health, the access number is 1-800-952-2335.
Okay. Thank you.
And I mean, because I'm school-based, I want to put in a plug that I think at least the public school systems in Santa Cruz County have worked very hard to create programs. Down in Pajaro, we have Pajaro Valley Prevention, And in Santa Cruz City schools, we have a head social worker who had brought people into the schools. So clearly those resources exist. I utilize them if I need to. I think they're very important. And there's suicide prevention. Interesting story. I had another client who actually wound up calling them and hung up, and the police got involved. And so, I mean, there are different ways that students can access information that they feel comfortable. What I tend to do is make sure that the people that I work with and the kids around me have access to that information. Again, because it's not necessarily clear what they're going to access first. And there's youth service, family services, so I think there are public institutions within the community and, you know, your local communities that are accessible. And I always encourage everybody to call and find out what your resources are. Obviously, you don't want to, in the moment, have to be figuring that out. And I think the phone numbers in the packets that you got are also very helpful.
I'd like to say that for the older adolescents who are moving into very young or young adulthood, it can be really, really tough to find the resources and the support that they need. And I think that it is a dilemma that we have in our community and all over the place about how we can provide therapists, social workers, clinicians to the people that are either in between, they don't have their own health coverage, they no longer fit into what is provided to youth in the community, and also the people that are really low income. So I think that's something for all of us to continue to work on. And I also would like to say that the phone number for Survivors Healing Center didn't get into the packet that you have. And so our phone number at Survivors Healing Center is 423-7601, and we do offer services on a sliding scale. We're also beginning to develop and will hopefully shortly be implementing more services for adolescents over there.
Thank you. Question regarding medications. Perhaps Peter, you might want to take a go at this one. The question is, since antidepressants now are being labeled as too risky, are mood-stabilizing medications, anticonvulsants being used more commonly now?
It's a very interesting question. You know, clearly when we're talking about medicine and how medicines change, one's talking about sort of broad, I think, historical phenomena about how the use of medications change over time. I'm actually not completely clear that there's been a marked shift from use of antidepressants because of the perception that they're possibly dangerous to use of mood stabilizers. But I assume those in the audience know the distinction here. Antidepressants such as Prozac, SSRIs, such as that, are used to treat depression and also to treat a lot of anxiety states. They're mood elevators and a lot of the time calming agents, although some of the time not calming agents, which is one of the problems of the small percentage of reactions that are agitated. Mood stabilizers were originally used for bipolar disorders, manic depressive disorders, lithium being the very first of those, Depakote, Tegretol, other newer agents, Lamictal, and so on, now also used. Over the course of time, the definition of bipolar disorder in the community or in the profession has shifted to include some states that would not 30 or 40 years ago have been called manic depressive or bipolar. Now we think of the spectrum between pure depression and pure bipolar disorder. I think quite a long time before the risks of antidepressants were dramatized by the black box warning, there was a shift going on to greater prescription of mood stabilizers, although that wasn't necessarily accompanied by less antidepressants. It was all part of the growing prescription of a lot of different medicines. I don't know what the statistics are right now about if there is a transition being quicker to mood stabilizing agents. These themselves, of course, have their own risks. And every time a physician or psychiatrist prescribes these medicines, they're always going to have to be weighing the risks versus the benefits. So I would hope extremely carefully. Certainly with behaviors such as self-injury, self-cutting, as we've been talking about on this panel, these are not behaviors that respond simply to a medicine. That sometimes we can help with severe symptoms of anxiety, obsession, severe depression by the use of medicines that then reduce the chance of these behaviors, or at least give some more chance to work with the person in their life and therapy without extremely destructive results in the person's life. But it's a shift, usually a relatively small shift compared to other things that are going on in their life and other aspects of the therapy, including, of course, the relationship with the therapy. I'm sorry, this is probably a complicated answer. No. But certainly the use of medicines and their historical change over time is quite a complicated phenomenon.
Well, I think to answer that question, the hard part is that you have to kind of know what it is that you're going to be treating. And, if you're talking about strictly major depression, without, any mania or hypomania, at least in the children's literature, there isn't really a lot of other evidence base for anything else that's that effective other than the SSRIs. And so, whether or not people are using mood stabilizers, I suppose they might be, hopefully not out of fear because of the black box warning, because in my mind, there's more evidence for the SSRIs than there are for the mood stabilizers, at least for treating major depression in kids. When it comes to using mood stabilizing agents in adolescents and kids, you also need to know that even for bipolar disorder, the number of studies in comparison to what we have for adults are very, very few, and certainly the number of good, well-controlled double-blind studies are very few and far between. And so, I would say that if the only focus of treatment is, using the mood stabilizers, there's not a lot of good evidence that that's the good way to go, and they have their share of problems and side effects too. So I wouldn't say that they're necessarily any safer than the SSRI antidepressants, and they, at least for major depression, they really don't have a strong indication or evidence base for people in the under 18 age group.
There was a question from a parent asking how they would work with their pre-adolescent child whose older sibling is engaging in some of this cutting and self-mutilation, and thoughts about that or advice for that parent? Good luck.
Again, I'll start and see what happens. I think it's a really great question, and I think it's very important to have open, to address it openly and to talk with the younger youth about the fact that this is a coping mechanism, but that there are many other ways to cope with these kind of strong emotions or stressors that are going on, and to really partner with that youngster in developing their own coping, figuring out what they could do to cope. Well, and I also think that some of these behaviors can be kind of secretive or private, so that the younger sibling might have a lot of questions, have a lot of concerns, observe behavior that maybe the parent isn't aware of, and be feeling that they're holding or keeping some kind of secret information. And it's important to bring in the older sib as much as possible, but to unburden them of feeling the need to be protective or be the secret keeper. So the very fact that someone's asking it suggests that that's the first step in the right direction, to kind of try to sit down, and if possible, I would get the older adolescent to help in figuring out how to talk with the younger adolescent. What do they want to have said? How do they want to have it handled? Is there a way that they could do it together with the parent? They may close some doors on that. They may not say anything, but at least you've tried to address it in an open fashion. Those are things that I would start with.
Anyone else with ideas on that one?
I think Dr. McCauley covered it actually quite well. It's really about the openness, and I think that's, as we've talked about this issue here today, one of the things that keeps coming up for me is the importance of not keeping this a secret, and that is true as well in families. So that encouraging families to talk about it, and I think that that's very hard for many families to do, and I think that's where you may want to get some help from a family therapist, some help and guidance on that, either sort of bringing the entire family in or just doing some individual sort of consultation with a therapist on how to do that.
I think it's also important to think again about what I think of as a spectrum. I think I'm maybe the most behavioral person of the people on the panel, but I think if you think about a spectrum of severity, there are certain things that you don't want to underplay or not take seriously, but you can at the early end of the spectrum, or a kid who's developing this behavior who doesn't have a history of significant trauma, you can do some normalizing. I don't mean normalizing by justifying, but by talking about habits, about talking about the ability to change habits that we've learned. We all have some ways that we've learned to cope that probably aren't going to get us where we really want to go in the long run. Let's look at other ways to cope. I think that those kids that are beginning to engage in this behavior, maybe because of peers, maybe as a periodic or occasional stress mechanism, or kids that you can really work with the families about kind of taking a habit reversal stance, which is less, I think, easier for families to wrap their minds around than some of the more difficult issues you get when you have kids that do have really significant histories of trauma, and you have a more complicated package to deal with.
Next question was for Dr. McCauley, but certainly others can chime in. You addressed a study that demonstrated that asking the question about suicide in adolescents doesn't seem to raise the risk for suicide. Dovetailing on that, why does there not seem to be much in the way of suicide prevention programs in school?
Well, you guys work in the school. I'll give a little entree so you can collect your thoughts, okay? This whole issue of school suicide prevention in school has been a very controversial field of study, and there was originally a series of studies that were done, I'm thinking probably in the 80s now, where there were a bunch of programs in the schools, and that didn't really have the effect that we would all want, because they seemed to be giving a message that overly normalized adolescent suicide, and almost a permissive, or almost gave a permission to engage in this. Okay, that's one of your coping mechanisms, let's list your other coping mechanisms, without any kind of sense of that is a coping mechanism we would like to decrease while we build up other coping mechanisms. So there was, then I think in the 90s and currently there's been kind of a rethinking about how we deal with adolescent suicide prevention in the schools, with a much more focus on, at least it's happened I know in Washington State, and I think probably in California, I'm going to defer to you guys as well, really very specific gatekeeper training programs. What are the signs and symptoms? What do you do if somebody says something to you or you think somebody's at risk? That have really been geared to informing teachers and principals and anybody working in the school and other settings where they interact with youth about what to look for and then what to do, because I think people get nervous about what to do, and really focused a lot on helping youth feel that they can speak up. And I think that we've been effective in that. The kids are, particularly about suicide, much more likely to speak up if they're worried about a friend. I was kind of encouraged to hear that you saw that about self-harming behavior, because I feel like we haven't quite gotten there about self-harming behavior, that kids are willing to speak up or feel the need to speak up. Then the other thing that's happened in youth suicide prevention work in the schools, these kind of broader-based things, is that people have found that so much of these behaviors are associated with other, adolescents aren't neat and clean and easy. Their problems come in clusters, and there's, frequently a couple of things going on. And so there has been a focus on looking more broadly at trying to identify kids who have mental health problems, not just focus on suicide, but more broadly, let's identify kids who are at risk because of mental health problems, or kids that are floundering in terms of their connection at school. So kind of getting at the at-risk youth from a lot of different approaches, as opposed to just focusing on this issue of suicide. And that's kind of where people are thinking at this point in terms of school-based youth suicide prevention programs. And there's a number out there that do screens for kids and then hook them into getting, there's Teen Screen, which is a Columbia-based program. And anyway, I'm going to defer to you guys at this point. Anything you want to?
I would echo what you said, Dr. McCauley, that yes, in the 80s we did a lot of talking with kids about suicide and showing movies and things like that. We now really do train our gatekeepers, and I think some of the other gatekeepers, though, that we do train are kids in our peer counseling classes and things like that. So when we do talk to kids about suicide, it's really about talking to them about being aware of things with their friends and how to help their friends by going to an adult, a counselor, a teacher, their parents, of really continuing to give that message very, very strongly to kids and not getting involved in talking about suicide as a topic for them, for the most part. We really stay away from that because we found that that's really not valuable. Bruce, anything else?
I may digress here for a minute. Because I've worked in the schools for a long time and also done a lot of training with teachers, I think part of what I've discovered in my work is that over the years, in the 80s and particularly in the 90s, there was a huge shift to somehow hold teachers accountable as socializing agents to our students, along with the identifier of mental health problems. Mm-hmm. And so I think, as Dr. McCauley said, there has been a shift, in a sense, to teach generalized skills to identify when there may be a mental health issue as opposed to a suicide issue, that if a teacher recognizes or a staff person recognizes behavior that somehow seems out of the focus or normalcy, that they would identify that to other staff. I think overall, again, it's difficult when we've positioned educators to somehow be the social agents of identification of mental health issues in the classroom. I think in general, in the state of California, we've worked hard in our educational settings to try to teach teachers in a way so that they don't necessarily feel a burden, but have an understanding of identification.
You know, I work less, well, I don't work with schools, but some of this does remind me of, working with the university and what I hear of how other mental health departments around the country work with the university settings where they are. And some of this is the same. I mean, the work with the gatekeepers is a really essential part of helping students. The residential staff are less than the teachers, probably. But there's one issue here that is rather a tricky issue, and interestingly, it really has come up a fair amount in the last couple of years. There are cycles in things with university students. It seems like for 10, 20, 30 years, all of the faculty and staff are in parental status with students and looking after their lives, and then they sort of step back and forget about them, and then they see that there's problems and tend to come back. I think in the 70s, for instance, there was a neglect of students. In the last 10 years, there's been much more interest in trying to help students with mental health problems and suicidality. And of course, a lot of that is extremely good, and a lot more resources are now, I think, becoming available. But there's one interesting issue that comes up, and that is that it's possible that the community, the university community, might end up wanting to solve the problem by not having the student there. And that, in fact, has come up in a number of lawsuits around the country of universities saying if you're suicidal, we get to know you're suicidal, then you are dismissed from the university, and then the student or the family suing them. I think it's a very interesting social issue. Clearly for us as mental health professionals, we work for the patient, and we're listening to them. But on the other hand, there's also this community there that sometimes has its own interest that's not entirely in the interests of the person that we're working with. And sometimes that puts us in quite a difficult position when we're advising the community. I think we tend to think of ourselves, I believe I'm talking for all of us, that we tend to think of ourselves as basically for the patient. But on the other hand, the communities also look to us for advice. I wonder if anyone has any thoughts about that.
Oh, very good.
I guess I could say that I do think you run into that even in high schools. I haven't run into it so much about suicide per se in that narrow, but kids who have really significant behavioral problems. I've run into it with a number of kids I've worked with really significant eating disorders where the school just wanted them out, gone, and feeling that need to serve as an advocate because feeling the importance for them to maintain that participation in that community. I don't have an answer, but I know it's a struggle. I think it is a struggle in high schools too.
Well, I'd like to give an opportunity for each of you to sort of making some closing comments, but I want to get a reminder in before we get to that part, is that if you guys could please fill out the evaluation that's stapled to the back of the beige course agenda packet. Once again, we use that quite a bit in coming up with ideas and ways to present the material each year. Actually, the panel concept was well received last year, and that's why it was brought back again this year. So any thoughts or suggestions you would have to please put in that. And maybe now in sort of as a wrap-up way, if we can maybe have a closing comment from each of you in terms of your experience from the program here, and then thoughts or visions for the future. Please.
Well, I just want to thank everyone for being here, and especially my colleagues from the schools, and appreciate that after a long day that you're here. One of the things that's come up for me as we've talked about this is the importance of taking this issue of adolescent self-harm and not just taking it as an issue that's outside of everything else, that's a separate thing that we look at, but to really sort of bring it in and look at that as a sign and a symptom of where else we need to look at with mental health for young people, and that hopefully we're not only just looking for those more serious kinds of signs, but we're looking for the other sort of pieces that come up about adolescence that we can pay attention to, so we don't have to be looking at the more serious signs of self-harm and suicide. And so just sort of that awareness that we have in looking at that. Thank you.
Thank you.
Well, I've been very impressed by the audience. I've been very attentive, I think, for the last 3.5 hours. Especially because I assume, are interested, a lot of you treat adolescents, and I assume you probably have a difficulty sitting still, like a lot of us who do treat adolescents, like adolescents. This has been a wonderful experience, I think, to hear the panel here and Dr. McCauley talk and give this overview that is really showing some of the large parameters of what we deal with here. And I want to echo, I think, the sentiments of the panel that are saying that really, in the end, the important thing is listening to where the adolescent is, where this person is going, what they're doing to themselves, to you, and to think that it has some meaning and is not a noise of growing up, I think.
I guess I would like to make two different sets of comments in closing. And thank you again for having me. But one set of comments is that even though I think adolescents are now facing a lot of stressors, I think it's a stressful time to be an adolescent, and a stressful time to be a parent of an adolescent. I think it's also, from the mental health perspective, there's a lot of really positive things going on. I think there's more gradually better and greater acceptance of the fact that people can talk about mental health problems. It's not so secretive. People don't feel like they have to be so secretive if they have concerns, mental health concerns, if they have even not mental health concerns, but doubts about where they're going and how they're going to cope with the things in their lives. I think we are becoming, in a good way, more open to that. I think we have very effective and for some situations fairly brief targeted interventions that can not necessarily solve all of the problems that these young people might be coping with, but can give them a set of skills that they can take forward and apply to other problems and maybe open the door to more in-depth focus on their problems as they mature. And then I guess a closing word for me is I think that one of the reasons I like to work so much with adolescents is because I have maturation on my side. So if I just hang in there long enough, they do mature and they do make developmental gains that can make them be much more successful. And I think it's kind of a holding moment where if you can hold and support and help to contain them through a difficult period, you get a tremendous payoff as they kind of move beyond you and mature.
Well, as probably one of two child psychiatrists that works for county mental health, I recognize every day that I probably couldn't work enough to see everybody that sort of wants to be seen, in the sense of people hoping that I have, an answer in terms of medication. But really, the people in this room I'm part of a much bigger team of folks. And, particularly in terms of delivering, community mental health and looking at it from like a public health model, I'm very appreciative that people are here and open to listening to, some of the treatments that can be effective, particularly for the chronic kind of self-injurious behavior, the people who, sort of do that continuously. Because I think that those folks are the ones that raise the highest level of anxiety for everybody in our treatment community. And people's willingness to sort of be open to sort of some of the newer treatments and some of the newer strategies, particularly ones that have a focus, because in order for us to treat all the kids out there that need help or treatment, we really need to have a strategy that's going to be efficient and effective. And that's what I struggle with every day in terms of who's coming in to be seen, who's the priority, who can really get good and effective treatment out in the community without having to see me or my colleague Dr. Doss. So I appreciate that people came here, and hopefully this is an incentive to spur people on to continue training and perhaps looking at cognitive behavioral therapy more, perhaps DBT or dialectical behavioral therapy as well. Thank you.
Thank you.
Two things in closing. One is that I would have to say that my greatest successes in helping people eliminate self-harmful behavior, particularly cutting, and heal, is a collaborative effort. That's the most outstanding element about it for me, and that it's really challenged me and challenges me to do my part of the showing up, and sometimes that can be pretty demanding. And the second thing I'd like to say is a little bit of an announcement, which is that April is National Child Abuse Prevention Awareness Month. And in the other room, Survivors Healing Center has these blue pages, and we're having a walk to stop the silence and end child sexual abuse April 21st in Watsonville. And if half of us showed up at the march, I think that would really make a big statement. So hopefully pick up a paper and join us, and let's see what we can do.
recently I was at a dinner regarding this conference, and somebody brought up leaching, new one on me, and we had an interesting conversation about it. The reason I bring this up is I think that this is a relatively new field that people are doing research in and investigating. And what I know as we all sit here is we need to keep asking questions and talking to each other, because there are answers we haven't discovered yet. The good news is, as I sit here, I see a huge community in support of kids. It's reassuring to sit with a panel, some of these people I know and some that I don't know, only by name. I think we have a great community here in Santa Cruz. I think we have really, really good resources. And over the years, because I've been here 30 years working with kids, I think relatively speaking, we've done an excellent job at keeping our kids safe and acknowledging their needs. And so, to me, this conference and being able to be here continues to acknowledge that that process continues, that we continue to educate ourselves and understand the changes that continue to impact our kids. And having two boys now that are relatively grown up, it keeps shifting. So when I look at my 20 and 24-year-old and the things that they went through and looking at what the kids go through now, it's different. And it behooves us to keep looking at what these shifts are about and what we can do. Quick piece of information for you. I found on the internet a place called the Cornell Research Program on Self-Injurious Behavior. I liked it because it referenced a broad base of other places that you can do, and they're doing some research in this area. So if you want more information, I would encourage you to look it up. Again, it's Cornell Research Program on Self-Injurious Behavior. Thank you.
All right. Well, thank you, Bruce, very much, and thank you all very much. And once again, if you just drop the evaluation things in the basket at the front door, we'd really appreciate that. And thank you again very much.
Oh, okay. I just don't know where the basket is. Out here.